Hi, I am Rafael Fonseca. I'm a hematologist at the Mayo Clinic in Arizona. At this meeting, we had the opportunity to present work we did to create a simulation that hopefully would allow us to make a decision as far as what is the best treatment to be used in someone who is newly diagnosed, transplant ineligible with multiple myeloma. For background, everyone knows that the SWOG study tested the triplet of RVD versus RD, showing its superiority with improvements in overall survival. However, in the subset analysis, patients over the age of 65 don't seem to derive this benefit. There's simply no evidence of improvement in overall survival there. So that was kind of point number one, which is one of the regimens that we use. Number two is we've seen the data presented for Mayo, so Daratumumab, lenalidomide, and dexamethasone, and again, I will be referring it to as Mayo, which has shown an improvement in PFS and overall survival, and that has been published. And if you just do what we call a naive comparison, it does appear that the overall survival and the depth of the response are slightly superior with Mayo, but there's no direct head-to-head comparison, right? So in the ideal world, we would have a randomized phase 3 trial to do that. So what we did is we took a simulation that used information that came out of Mayo for the DARA-RD. Then we used real-world data set to establish the front line with RBD, although we did this as well with the SWOG studies, and the results are pretty much the same. Then we ask ourselves, we have data with Pollux that is used for the relapse and refractory myeloma, but the patients in Pollux wouldn't be the ones that you would see in Mayo. They were about 10 years younger, and about 60% of them got a transplant, so it's a different population. So how did we go about doing the control for the second line? So we looked again at Flatiron Health database. We looked at patients being treated with carfilzomib, pomalidomide, and daratumumab. So this is how it goes. If you start with DARA-RD, then we assume for second line you're going to get carfilzomib and pomalidomide. If you start with VRD or RD, then we assume you're going to get daratumumab-based combination at that point. Now, to complete the model, we put an attrition rate in the center. We did a sensitivity analysis with multiple ranges for attrition, but even if you take the most conservative one, it's 27%. We would consider that very conservative because we have published before that per line of therapy in the transplant ineligible patients, you may have a loss of up to 50% per line of therapy. So that's why I call it conservative. Okay, so we ran the simulation. What we found is that the median projected overall survival, if you start with RRD, have that attrition, and then get a first-line treatment with carfilzomib, pomalidomide, we're talking about 9.1 years, which is about 2.5 years longer than what our simulation would predict if you start with RBD and then you get to daratumumab, and it's about 3.5 years longer than if you start with RD and then continue with daratumumab. We actually compare this to also at 5, 10, and 15 years. So you can see we're not quite there at normal life expectancy, but very significant improvements, and we hope this, guides clinicians, particularly because both regimens are contained in all guidelines, in the MSMART, NCCN, and parenthetically, I add, and even though it's not part of my study, that with the DAR regimen, you have a neuropathy-free regimen. So I hope this is illustrative and informative, and we appreciate the opportunity to present that work.